the Bureau of Health Workforce Grand Rounds webinar series, Building Health Equity, the link between social determinants, healthy communities, and workforce training webinar. Today's presentation can be downloaded by clicking on the files located in the bottom right-hand corner of your screen. When the file is highlighted, click the Save to My Computer button. You'll then be able to save the file in the location of your choice. At the conclusion of all of our presentations today, there will be an opportunity to ask questions over the phone and online. The operator will provide you with instructions on how to submit a question over the phone, and to type in a question, you can do so by typing in a question into the chat pod located underneath the presentation. Thank you again for joining us today, and we hope that you find the webinar incredibly helpful. I'll now turn the presentation over to Tara Spencer.
Thank you, Carl. So the agenda for today, we will go over the purpose and objectives of this webinar. We will give the BHW and HRSA perspectives, followed by speaker presentations, and lastly, followed by a question and answer session. The purpose of today's webinar is to highlight efforts combating the social determinants of health as relative to different populations and how they are used to educate and train health professionals. Objectives for today: identify health workforce education and training that address social determinants, and understand a new framework for intervening in the social determinants of health. We will now start with the Bureau of Health Workforce and HRSA perspective by Captain Sophia Russell. Captain Russell is a member of the United States Public Health Service Commission Corps and is the director of the Division of Nursing and Public Health at HRSA in the Bureau of Health Workforce, where she is responsible for the strategic guidance for a $330 million a year portfolio of programs spanning over more than 800 federal awards in disciplines in nursing, public health, behavioral health, and 2 national coordinating centers. In this capacity, Captain Russell serves as principal advisor on strategies and decisions regarding national policy with regard to support of nursing practice and education and behavioral and public health programs. Captain Russell holds a Doctorate of Management degree in Organizational Leadership from the University of Phoenix and received a Master of Business Administration with a concentration in Corporate Finance from the Johns Hopkins University. She is a graduate of Norfolk State University with a Bachelor of Science in Nursing and holds a postgraduate certificate in Global Health from the University of Maryland. She is board certified as a nurse executive by the American Nurses Credentialing Center. Captain Russell has spent the vast majority of her nursing career working in the field of nursing administration and workforce development and management. She began her nursing career through the Army Specialized Training for Army Readiness, or STAR program. Over the course of her 24-year nursing career, some of her assignments include tours of duty at the Office of the United States Surgeon General, Division of Commissioned Corps Personnel and Readiness, on staff at the Defense Health Agency and TRICARE Management Activity, on staff at the National Institutes of Health, National Cancer Institute, and as a staff nurse with the Department of Justice Bureau of Prisons. I now present to you Captain Sophia Russell.
Thank you, Tara, and good afternoon, everyone. I am Sophia Russell, the Director of the Bureau of Health Workforce's Division of Nursing and Public Health. I bring you greetings from our division and thank you for your interest in our program. Our vision seeks to realize the full potential of combining health workforce functions such as awarding grants, loan repayment, and scholarships with health workforce research and health workforce monitoring. To fulfill this vision, the Bureau has to be creative about the way we do business today. This is true in the way we shape the conversation about national health workforce policy, the way we manage funding opportunities, and the way we operate between the Bureau and the communities where service is provided. The Bureau of Health Workforce provides strategic coordination, alignment, and enhanced communication between HRSA's workforce programs to address shortages in underserved areas, and develop ongoing strategies to monitor, forecast, and meet long-term health workforce needs. So our approach starts with research and data. Through our National Center for Health Workforce Analysis, known as NCWA, We track national trends and examine issues that impact supply and demand, distribution, and preparation of the nation's health workforce. Informed by NICWA's research, we address these trends by developing responsive programs and health workforce policies, applying resources to where gaps and needs exist. Our key focus areas, including telehealth, rural and underserved populations, and community-based trainings, guide our approach as we create programs and funding opportunities which leverage academic and community partnerships to prepare health professionals to address existing and emerging public health issues in underserved communities. Build capacity by expanding training and practice environments to deliver coordinated, multidisciplined, team-based primary care, and enhance health outcomes by promoting value-based care centered on innovation, efficiency, and effectiveness. As we follow this approach, the Bureau of Health Workforce works to create a well-distributed and robust workforce supply of diverse, culturally competent health professionals who provide quality health care to communities in need. The World Health Organization defines social determinants of health as the conditions in which people are born, grow, live, work, and age, along with the systems put in place to deal with illness. The social determinants of health are mostly responsible for health inequities, the unfair and avoidable differences in health status seen within and between populations and countries. At the Health Resources and Services, pardon me, I just had the wrong slide. So this slide depicts the conditions which are shaped by a wider set of forces that include, as the slide depicts, the local environment, economics, education, social and community context, and access to health care. So by addressing these factors, we will be able to reach our ultimate goal to improve the overall health of the population and achieve health equity. At the Health Resources and Services Administration within the Bureau of Health Workforce, we're taking steps to help address social determinants of health with our workforce training program. In FY17, the Bureau of Health Workforce was able to make 248 awards totaling over $139 million to 10 programs that support addressing social determinants of health. These awarded programs address the social determinants of health in the communities in which they are providing care in their curricula or with student populations being trained. Our 10 programs support disciplines of nursing, medicine, oral health, behavioral health, as well as other health careers. Additionally, HRSA's Bureau of Health Workforce's resources are outlined on this slide. We have the Health Workforce Connector, which is an online tool that helps connect skilled health professionals to jobs in communities with limited access to medical, dental, and behavioral health services. HRSA's virtual job fairs provide an opportunity for those seeking employment to connect with potential employers from across the country. These free online events occur throughout the year. Also, HRSA provides resources on various health topics. The Bureau of Health Workforce's Alzheimer's disease and related dementias curriculum trains the primary care workforce about dementia care and helps providers address caregiver needs. This curriculum is comprised of 16 core modules and 11 supplemental modules for providers and caregivers. The Intimate Partner Violence Toolkit helps build a comprehensive and sustainable response to intimate partner violence. The toolkit provides step-by-step guidance on how health centers can identify and respond to intimate partner violence. And I'll turn it now over to Michael Jenkins.
All right. Thank you, Captain Russell. So now we will transition into our presentations, of which our first presenter is Dr. Anthony B. Eichen. Dr. Eichen is Senior Vice President of Healthy Communities at the California Endowment, the state's largest private health foundation. His primary focus is on the foundation's 10-year Building Healthy Communities California Living 2.0 initiative, the goal of which is to create communities where children are healthy, safe, and ready to learn. Prior to his appointment at the endowment, Dr. Eichen served as both the Director and County Health Officer for the Alameda County Public Health Department. In that role, he oversaw the creation of innovative public health practice designed to eliminate health disparities by tackling the root causes of poor health that limit quality of life and lifespan in many of California's low-income communities. For 3 years, Dr. Eichen also served as Director of Health and Human Services and School Medical Advisor for the city of Stamford, Connecticut. Concurrently to that, he also served as a physician in internal medicine for Stanford Hospital's HIV clinic. In addition, Dr. Eichen served for 5 years as the primary care physician for the San Francisco Department of Public Health. Dr. Eichen's varied career also includes past service as a staff attorney and health policy analyst for the West Coast Regional Office of the Consumers Union, the publishers of the Consumer Reports magazine. Published in numerous public health and medical publications, Dr. Eichen is a regular public health lecturer and keynote speaker at conferences across the nation. He earned his Bachelor's of Science in Neurophysiology with honors from McGill University, his JD at the University of California, Berkeley's Boalt Hall School of Law, and his medical degree from Johns Hopkins University School of Medicine. Now we will have Dr. Eichen.
Hi, good morning. I hope you all can hear me. And I'm going to take you on a slightly different journey, trying to get underneath what a practice of health equity looks like, a practice that's seeking to advance health equity. So I'm just going to jump right into it because I only have 15 minutes. So the big question for many people who are practicing in local and state public health is, when you look at the data, when it comes to your health in this country, does your zip code matter more than your genetic code? And that's what I'm going to try to illustrate to you. So this is a picture of the San Francisco Bay Area where I now live. And this little circled area here is the city of San Francisco, for those of you who don't know what San Francisco looks like on an aerial map. And I became the health officer and health director of Alameda County, which is this big green boot-shaped area here of about 1.5 million people. And I'm showing you this because I'm going to show you a couple of maps in a second, and I want you to be able to recognize the shape of Alameda County. When you're a health officer, you become the recorder of all births and deaths in the county. And Alameda County has about 20,000 births a year, about 10,000 deaths. And each of those deaths has a death certificate which tells you what the person died of, how old they were when they died, their race, ethnicity, and where they lived. And you can take those 4 data elements from death certificates and actually create an interesting portrait of how death is distributed in a place. We took about 400,000 death certificates in Alameda County over a period of close to 50 years. And we wanted to analyze the patterns that we saw to explain what many of our health practitioners in our public health department were witnessing on a day-to-day basis. And so the first thing that you can do when you do that analysis is you can take Alameda County, which again is shaped like a boot. In the foot of the boot is the older part of the county, which is Berkeley and Oakland, and then there's, going down towards the heel, there's sort of a 1970s era set of freeways and suburbs, and up along where the laces would go, there's a set of 1980s era suburbs, and then in the back of the boot, you've got really kind of rural land primarily. And so we took every census tract in Alameda County, and we calculated using death certificates the average age to which somebody could expect to live in that census tract. And so you see the green areas are where people can expect to live greater than 80 years. The yellow areas are between 74 and 80 years, and the red areas are less than 74 years. And those red areas concentrate in the older part of the county and the flatlands of Oakland and Berkeley, and then sprinkled along some of the unincorporated parts of the county going down towards the heel. And this was a surprise to us. We expected that deaths would be randomly distributed across the county, and when we looked at this analysis, we found that that was not in fact the case. As I started to show this map to others around the Bay Area, it ended up on the front page of the San Francisco Chronicle. People started to wonder whether this was something unique to Alameda County, so we decided we would go around the country and look at other places to see if we could calculate life expectancy differences across relatively small geographic areas. In the city of Oakland, we calculated a 22-year life expectancy difference between the flatlands of Oakland and the Oakland Hills. So when we went around the country, we took our map in Alameda County. We went to Baltimore, Maryland, which is where I went to medical school, and did the same analysis with the City of Baltimore Health Department, and they found neighborhoods in Baltimore with life expectancies in the low 60s, and other neighborhoods in North Baltimore with life expectancies in the high 80s, approaching 90. We also went to Cuyahoga County, Cleveland, found a similar difference of almost 30 years. We went to Denver, found significant differences there. Went to New York City. We went to Seattle-King County, to Los Angeles, to Minneapolis-St. Paul, to Boston, to Philadelphia, to El Paso. Everywhere we looked, and we continue to look, we're finding differences on the order of 15, 20, 25, and in one case, as I mentioned, almost 30 years in the same city of life expectancy differences between neighborhoods. So trying to understand what's happening there, we took the map of Alameda County again. The left upper there is the life expectancy by census tract, and then we correlated that with poverty by census tract. And when you correlate those two things on a simple bivariate correlation, you see this relationship. On the left, each of those blue dots is a census tract or a neighborhood in Alameda County. And on the left, you see relatively wealthy neighborhoods. On the right, you're moving into poorer neighborhoods where the poverty rate is increasing. And as you move from left to right in Alameda County, you see life gets correspondingly shorter on average. We called this the Alameda County death tax. This is the price that low-income people pay for living in a low-income neighborhood as measured in terms of fewer years of life. We did a similar analysis for the entire San Francisco Bay Area, which is what you're seeing here. We, in fact, did every census tract in California. And you see these patterns, and the slope of that line, we think, has meaning to it. We think that opportunity is distributed inequitably and accounts for the slope of that line. And interestingly enough, the slopes of lines on the West Coast are much shallower than the slopes of lines on the East Coast. In the longer version of this presentation, I would show you that, but I only have a few minutes. So you can't put a scattergram or a regression line on the front page of the newspaper, but you can monetize the slope of that line and come up with this, that in the San Francisco Bay Area, every additional $12,500 in household income buys you a year of life. And then you can compare that monetized slope to other places around the country, which we have done. Another interesting piece of information for those of us who practice in the world of trying to address health disparities and create health equity is this data point, which many of you hopefully have probably seen. It comes from Elizabeth Bradley and Lauren Taylor, who were respectively at Harvard and Yale. And they took something that a lot of people had looked at over the years and not thought to do. They took per capita spending on U.S. healthcare, arrayed across developed countries, and they added to that per capita spending on social services. And they found that when you do that, the U.S. is no longer the big spender. The U.S. is actually kind of comfortably in the middle of the pack of developed countries, except that we seem to have the accent on the wrong syllable. If you look at the blue spending there, you see we're the biggest spender on healthcare per capita, but on social services, we're amongst the lowest spenders in the developed world. And when you add those two things together, we're not spending more money than the rest of the world. We're just spending our money badly. They went on to show that in the OECD, which are basically a constellation of developed countries around the world, for every dollar spent on healthcare, $2 is spent on social services. And they found that that's about the right ratio for the best health outcomes. In the U.S., we spend about 55 cents on social services for every dollar on healthcare. So we literally are completely inverse to the bulk of the developed world. And we argue that that spending on social services is essentially spending on a social compact. A social compact is essentially investing in those things that take the sting out of poverty. Those are the supports like universal health care, like child care subsidies, like education subsidies, including post-secondary education, paid leave, unemployment supports. All of those things take the sting out of poverty. In the United States, we leave the sting in poverty. And the social cost of being poor is substantial, and it's exacerbated by the failure of policy to buffer low-income people from the consequences of essentially having to navigate a difficult opportunity landscape in every possible domain. So I'd like to say, don't believe me, believe the Institute of Medicine, or now called the National Academies of Medicine, who produced this report in 2013 called Shorter Lives, Poorer Health. Amongst their conclusion was this: the panel was struck by the gravity of its findings. For many years, Americans have been dying at younger ages than people in almost all other high-income countries. This disadvantage has been getting worse for 3 decades, especially among women. And the U.S. health disadvantage cannot be fully explained by health disparities that exist among people who are uninsured or poor. As important as these issues are, several studies are now suggesting that even advantaged Americans, those who are white, insured, college-educated, or upper income, are in worse health than similar individuals in other countries. So the evidence is suggesting that it's not just our low-income people who are impacted by our lack of a social compact, but it's across the entire income spectrum in this country. We're in worse health than we should be given our general wealth. Many of you have seen over the past few years this notion of deaths of despair, which seems to be focused on white rural Americans. This is the PBS NewsHour asking why so many white Americans are dying young. This is the Wall Street Journal looking at life expectancy declines for white women. And here's an article on deaths of despair. This is Newsweek asking about why white Americans are dying younger. And this comes largely, or at least it was popularized largely, because this was known in the public health circles for quite a while before these two economists, Angus Deaton and Ann Case, popularized this notion in Deaths of Despair, and then Angus Deaton won the Nobel Prize in 2015, so he got a lot of press for this. But amongst their findings was this finding, which looks at mortality rates from roughly 1990 to 2010, showing what one would expect to be declining mortality rates throughout most of the world, including in the United States. If you look at that thick blue line, that's looking at U.S. Latinos. If you were to plot U.S. blacks on this line, you would have to change the axis of the graph, because U.S. blacks are above all of this, although declining during this period along the same slope as most of these other lines. But when you look at that thick red-white line, you're talking about U.S. whites. And not only is that line, since about late 1990s, no longer really in decline, it appears to be plateaued or rising, which was shocking to many people. And so in my job, I spend a lot of time trying to shout this from a mountaintop. So we have popularized this idea of zip code and being more important than your genetic code, using essentially a narrative change campaign, trying to illustrate what in fact is driving the health disadvantage that this country is facing and the disadvantage that low-income people of color are facing across the country. So we use real zip codes and real life expectancies, real zip codes and real high school graduation rates. When California's capital is in Sacramento redid its airport a few years ago, we decided we'd have a conversation with our state legislature on the walls of that airport. So we started posting this across this new terminal, and I started getting calls from legislators asking why I was reducing property values in their districts. So we know that they were seeing it. This is the American Public Health Association meeting in San Francisco a few years ago, where we literally festooned downtown San Francisco with these images. This is the governor's office a few years ago where he graciously allowed us to put this outside his office for 4 months. And so what we're arguing is that while healthcare is important, it's not sufficient, and that fundamentally what's happening is chronic stress, this notion of allostatic load, that by virtue of not investing in a social contract or compact, we're essentially leaving people to be unbuffered by the effects of poverty. And in this country, it may be things like housing stress, being socially isolated, experiencing racism, crime, lack of access to basic amenities, so-called high-demand, low-control jobs, which create an enormous amount of stress, and the body interprets stress through the hypothalamus, sends a message to the pituitary gland, which sends a message to the adrenal gland, which releases a cascade of hormones, amongst which is cortisol. Cortisol is good for you acutely in the blue here. When you're stressed, you need increased cardiac output. You need to rally glucose for your muscles or for your fight or flight response. You need to enhance your immune functions, and it stimulates growth of neurons in your hippocampus and prefrontal cortex. But when you're chronically stressed out, when you're chronically bathed in cortisol, you're in the red now. And it does almost the exact opposite. It stimulates hypertension and cardiovascular disease. It stimulates glucose intolerance and insulin resistance. And it increases in inflammation and turns down your immune system, and then causes atrophy and cell death in that same part of the brain that's responsible for what's called executive function, which is really the ability to do triage and choose between relatively different things and make the best decision for the circumstances that you're in. So our argument is that we need a workforce that understands this. We need a workforce that understands that people that are living in low-income communities that are unbuffered by good social policy or a social compact are experiencing high rates of stress, which changes their physiology and ultimately changes their genetics as well. The argument is that when you see disparities, you're not seeing the inequities that lie under the surface that create those disparities. So we've created this framework, which we think is useful for people to try to understand how to intervene in this work. And specifically, it takes the medical model, which is basically a simple linear notion that risk factors creates higher burdens of morbidity and disease and injury, which creates a higher burden of mortality and premature death and decreased life expectancy. And the variables that we can essentially vary in the medical model are individual health knowledge, primarily through health education, access to clinical care, primarily in 15-minute clinical interventions, and then we try to tinker with people's genetics, but it generally doesn't work and it's very expensive. So we argue that that's all necessary but insufficient, that we also have to look at the socioecological context. And we argue that there's fundamentally a set of discriminatory beliefs that have created a narrative in this country about who belongs and who doesn't belong, and that has created policies and practices amongst powerful institutions that ultimately steer resources towards people who are favored and away from people who are disfavored. And we also note that immigration and family and culture creates a buffer against the conditions that people find in low-income communities, but as people acculturate, that buffer starts to fade. We argue that health disparities occur downstream, health inequities occur upstream. You can take the word health out and just talk about inequities producing disparities, or if you're simple-minded like me, you talk about conditions producing consequences. And we argue that we need to spend less time just managing consequences and more time changing conditions. So very simply put, our framework says that the medical model says bad behavior produces disease, produces death, and the socioecological framework says that bad societal behavior in the form of isms creates policies and practices that leave communities that are on life support. And so we've pointed out that we have interventions to prevent death. We call those emergency rooms. We have interventions to try to change the course of disease. We call that clinical care. We have interventions to try to change behavior. We call that health education. All of that is necessary, not sufficient, and costs about $3 trillion a year. What we don't have are interventions to try to intervene in neglected communities. We argue that the fundamental aspect of that intervention is to build social, political, and economic power in a critical mass of people living in those communities, and that has health workforce implications. in terms of the types of health workforce we need to actually address community health. We argue that it's not just neglected communities that we have to tend to. We have to look at policy and leveraging different sectors, and we think that that has profound health workforce implications as well. And finally, we think that we have to change the narrative. Also, profound health workforce implications there as well. The work of health equity, we call them the drivers of change, lives upstream in that area, and that's the new health workforce we need for the 21st century if we're interested in trying to undo health disparities and the underlying inequity that drives it. Very simply put, this is just another way of saying the same thing. The medical model says behavior, disease, and leads to death, and we try to manage that primarily through clinical interventions on individuals. The Socioecological Framework says that we now, in the status quo, have an exclusionary narrative that essentially says some people are deserving, others are not. And that leads to a weak social compact where some people have benefits, other people do not, and that creates social vulnerability. We think that the work of health equity, again, with profound health workforce implications, is shifting that narrative from exclusion to one of inclusion and belonging, which is what we're doing in California, to what we believe is great effect. We think that we need to reweave our social compact in this country, which starts with things like universal health care, child care, paid sick leave, et cetera. And we think that ultimately we need to help create and maintain strong and resilient communities. So that's what we think is critical in this work. We think that this is what health looks like, particularly in low-income communities. Some people are frightened by this. We argue that health is political. If you define politics as a struggle over the allocation of scarce and precious social goods, this is what health looks like. These are communities standing up for clean air, standing up for access to health care, standing up for a school system that doesn't create a pipeline from the schools into the criminal justice system. This is what we think health looks like. And I think I'm going to stop there for time, and we can address some of these other things in the Q&A.
All right, thank you very much, Dr. Eitzen, for that very informative presentation. So keeping it moving, we will have Dr. Janice Probst to present next. Dr. Probst is a professor in the Department of Health Services Policy and Management, Arnold School of Public Health, University of South Carolina, and director of the South Carolina Rural Health Research Center. The focus of the South Carolina Rural Health Research Center is disparities experienced by rural, minority, and vulnerable populations. Dr. Probst has over 125 peer-reviewed publications across her career. Recognition for her rural health work includes the Outstanding Researcher in 2008 and Volunteer of the Year in 2016 awards from the National Rural Health Association and the Martin Luther King Jr. Social Justice Award from the University of South Carolina in 2013. Now to turn it over to Dr. Probst.
Dr. Eitzen is going to be a very hard act to follow, but I will try my best. And as you can see from my affiliation, what I'm going to talk about today, because it's in the title as well, is the social determinants of health in rural and urban populations. But of course, I'm going to emphasize the rural a little bit more because that's where my heart lies. And I got entranced a few months ago with the concept of SOAP notes, which I believe we have a lot of nurses on this call, and some of the older nurses may remember being asked to describe a problem in terms of SOAP notes. The subjective, how people perceive a problem, the objective, what is measurable, what their assessment is, and what their plan is. Now, since I'm not a workforce expert, as like some of the other folks here are, I'm going to leave the plan part a little blank, as you can see down there, but talk about some of the perceptions of rural versus urban disparities in social determinants, go over some of the actual measurable determinants, and then talk about, perceive the determinants of health, what are measurable disparities in mortality, paralleling what Dr. Eitzen talked about, assessing the role of social determinants, and then a little bit about what
some workforce information that's already out there that we may need to address in our educational program. Cool. Being a professor, and since most people do not know what the rural U.S. means, I always start out with, what is the rural U.S.? For you guys in California, I'm really sorry because maps that are county-based show much of California as being urban. We all know that once you go east a ways, it actually isn't. But nonetheless, these are roughly all the areas in gray using this USDA map are rural America. And rural America is everywhere from the top of Maine all the way down to, obviously, Alaska to the bottom of Texas. It's everywhere. One of the things I wanted you also to keep in mind, remembering where rural is that rural populations do vary. Rural is not all white people plowing to a Bob Seger song. There is a substantial concentration of minority populations, and it's in specific locales. As you can see here, the rural population of Hispanic or Latino persons is concentrated in the West. I'm sorry, California, you would light up if you were not also urban. The population of Black or African American persons is largely in the historic South. And I want you to keep these locations in mind, because when I have subsequent maps that illustrate disparities in the social determinants of health, you will see that these areas that are associated with minority populations tend to light up as well. Okay, so that was my definition section. Objective, what is rural America? Here is the subjective on rural America. And as was pointed out, the world is ending. Of course, it's mostly ending because white people are suddenly dying as opposed to persons of color, but there you go. You've got the deaths of despair. I'm sorry, I'm just weeping. You have despair in the American heartland. You have Hillbilly Elegy, a memoir written by a brilliant person of 35 showing how he overcame all the handicaps of his family, from whom he derived nothing. But moving on from that somewhat cynical thing, there is this notion that rural America is totally in downfall, and it's probably their own fault. But this problem, which we are all of a sudden, and Dr. Eichen did a very good job of presenting that, talking about despair as the diagnosis of the day. When you look at the data across rural America, we have had consistent mortality disparities that date back, at least 20, 25 years. If you'll notice in this nice little map, this is from a nice article appearing in the Journal of Rural Health. If you'll look at the black, which as you'll notice, you almost have to change the scale, and the white mortality rates divided by rural and urban, they're all going down, and things are really going nicely down here on the lower, the gray line for white people, until about the mid-'80s, at which point you'll notice that the rural line, which is the solid gray line, somewhat flattens out, while the death rate among urban populations continues to go down. And there's that break point roughly there. There is a similar break point for the African American population. At some point, and I have some hypotheses about these, but that's not the purpose of this talk, at some point things continue to get better for urban dwellers while they stay the same for persons who live in rural areas. There are additional sources for this information that are a little bit more recent. The Robert Wood Johnson Foundation, with its county health rankings, has been providing lots of nice charts and data that allow people to analyze this on their own. And their data supports what we see elsewhere, which is the trends for premature death. As Dr. Eichen pointed out, they are not evenly distributed. From a national perspective, there is a penalty, if you will, for living in rural America and providing the rest of folks who live in urban areas, you know, with their food, their energy, that sort of thing. And the situation has not been getting better. Not only are the disparities present, but you'll notice that in rural areas, rural counties are much more likely to have a worsening death rate, whereas in large urban metro, they're all sort of improving. if you can see the blue bars, the light pale blue bars are counties that are improving, which tend to be disproportionately urban counties. Although some rural counties are getting better, a substantial proportion, approximately 1 in 5, are getting worse over the period between 1999 and 2013. So we've got our subjective, the world is ending. We've got our objective, persons who live in rural areas are more likely to die and to die early. Our assessment phase, what are some of the causes or factors associated with these early deaths? And I'm going to argue that there are 2 sets of causes. One is the proximate, and this very neatly parallels what Dr. Eichen just presented for us, the proximate causes of excess mortality, the things that people may do, those adverse behavior patterns, a problem that affects rural America far more than it affects areas like San Francisco, a literal lack of access to care, not just financial or subjective, proximate causes of excess mortality. And I will go to ultimate causes next. But here I've got, because I was told that I had to keep myself within 15 minutes, I have one slide on proximate causes. And we're going to sort of read across that slide from left to right, and we're going to see that deep breath. The CDC in 2018, from beginning in 2017, going into 2018, did a series of studies of rural America. One of the ones that they did, and its data is presented in red here, they looked at non-core rural counties and looked at several behavioral attributes. What I did in this slide, because to me, when you only look at the most rural of rural, which is what non-core rural communities are, the question becomes, compared to what? So I went and did a really quick download of the behavioral risk factor surveillance system and created some comparison data. And to make it simple, because I only get one slide, this is black adults. So I was taking a population that might generally be expected to have bad results and said, in this population where fair or poor self-reported health is most likely, what does it look like for urban and rural? And going across, you'll notice that from left to right, fair to poor self-reported health is worse for black persons living in rural than for urban. Black persons living in rural areas are more likely to delay visiting a physician due to cost, are more likely to be uninsured, are less likely to have an age-appropriate mammogram, and are more likely to be obese. So, and this is like, these comparisons play out across other populations. So all of these precursors of death are worse in rural. But I said that was the proximate cause. Let's go to the underlying causes of disparity, which I would argue, as Dr. Eichen has, are further downstream or upstream, or however, I get lost in directions and streams. But in any case, the things that are further back, a poverty of education and resources, which leads people to be less able to care for themselves. So I'm going to go through some of these, and for those of you who do not study rural, this may be a surprise. It may not. Poverty rates, historically, as long as they have been measured, are greater in rural than in urban America, as you can see from this wonderful slide from the U.S. Department of Agriculture. This problem is particularly the case, as one would imagine, among minority groups. And poverty is higher for every single one of these groups, moving from left to right, for white, for black, for American Indian, for Hispanic. Everybody you live in rural, you're more likely to be poor. And what is heartbreaking to me, and this is almost is that these poverty rates are highest among children. If we are really going to worry about the upstream area, what are we preparing our children for? And in some of our South Carolina counties, I know that our minority poverty rates are in excess of 80% for families with children. Again, some more geography. Notice where the persistent poverty counties are. Places where 20% or more of households with children 18 and under 18 are poor. They track the predominantly black areas of the South, the Hispanic areas of the Midwest, and Indian country in the upper northern portions of the country. If where you have poverty in a world where school systems are generally supported by local revenue, you're also likely going to have educational disparities, both as a result of poor school systems and contributing in a big circle. Note just this chart you can download and study, but you'll notice the bottom line is that 51% of rural adults versus 39% of urban adults have a high school education or less. That has a lot of implications for how you treat people, how you educate people. And you'll also notice that this is even among persons who are relatively young. There is a disparity of 17% of rural adults between the ages of 18 and 24 not having graduated high school versus 13% of urban adults. While some of them may make it up eventually, it's not likely. What are some of the causes of these educational disparities? I'll just toss off a little bit. How do you like this one on segregated public schools? Here I have chosen to just illustrate the share of black children attending majority non-white schools. Here in South Carolina, and I suspect throughout much of the South, we have two school systems. We have the public school system, which is predominantly minority, and actually was featured in a documentary called Corridor of Shame and was visited by President Obama in his 2008 campaign, where the public school systems are highly minority. All of the white children go to private schools. Okay, so there are similar slides available from that source pertaining to Hispanic populations. What are other problems? Unemployment. Here I've just got a slide looking at regional differences. Some of the same minority areas that live up for poverty and poor education, along with Appalachia, light up for unemployment. And this is an interesting factoid too, that unemployment is highly related to opioid events such as deaths or emergency department visits. And what this blue slide shows is the percentage increase in overdose events associated with a 1 percentage point increase in unemployment. And of course, we have the great divide of who has and who does not have health insurance, with the darker states being particularly those who have chosen not to expand Medicaid. And when you don't have health insurance, but you might need to go to health care, what do you get? You get households with medical debt and collections. Again, another one of those things that in terms of poverty and stress, are you going to go to the doctor's office when it means that a collector's organization is going to be calling you? And again, you'll notice that these areas get concentrated particularly in certain counties and certain areas, and enough stated, you can probably draw your own conclusions. So I've done subjective, objective assessment. Where is the plan? And can they be addressed within healthcare? Now, actually, I should have modified this slide to say previous and next speakers are going to adjust it. But I'm going to throw out one last point that I think we need to educate persons on, which is that current practitioner perceptions may make the task of preparing clinicians who can address the social determinants of health more difficult. These are very interesting studies that just came out like at the beginning of June. It's the percentage of physicians recognizing the social determinants of health. And I've selected a few items to highlight from this very wonderful study. Information about water quality, help getting affordable housing, help getting sufficient food, and help arranging transportation. And you'll notice that all of these have a proportion of physicians thinking they're important. Transportation, 66% are important. Help getting sufficient food, 48% say that would have a great or moderate effect on their patients. Affordable housing, people know that they're there, right? I mean, physicians are not living in an like with blinders on in like little gated communities or something. But who will bell the cat? There is the red line on the bottom is the proportion reporting that the physician, him or herself, is responsible for addressing this. The pink line immediately above it is other medical staff. The gray line, okay, well maybe it's the admin staff in our office, but you'll notice that for most of these problems, for all of the problems, the majority say somebody else should be taking care of it. The only one that's different there is transportation, which is really interesting. I think if we are going to change this practice, we have to change this perception. People aren't going to do what they see to be somebody else's job. Somebody else is doing it. Well, why aren't you guys doing it? Well, there is that big thing about, it's somebody else's job. There is some people still who say it's not appropriate. You can see the numbers vary from 48% saying it's not appropriate for a doctor to help you get housing down to 22% saying it's not appropriate for them to get food. Again, there is this perception, as shown by these pink lines, that there is somebody else who's doing this. Somebody, but there's still a big gap. If you'll notice that, it's not my job, somebody else is doing it, there's still a whole lot of space that could be filled up that isn't, that is possibly an area that the physicians haven't thought about, okay? This slide says it's somebody else's job, that's all that yellow stuff. This slide suggests maybe we haven't figured out who is doing it. So, my wrap up really close, because I'm still going over, is that the prevalence of adverse social determinants of health varies a lot, but it is really going to be difficult to find solutions. I leave that to all the people here who sound way smarter than me. There's our thank you slide, and there's our obligatory nod to our funder slide. Thank you.
All right, thank you, Dr. Probst, for that wonderful presentation. Next, we will have Dr. Sandra D Lane. Dr. Lane is a professor of public health and anthropology at Syracuse University and a research professor in the Department of Obstetrics and Gynecology at Upstate Medical University. She received her PhD in medical anthropology from the joint program at the University of California at San Francisco and Berkeley, and an MPH in epidemiology from the University of California at Berkeley. In addition to her 47 published articles and 23 book chapters, Dr. Lane has authored the 2008 book, Why Are Our Babies Dying? Pregnancy, Birth, and Death in America, was co-authored on 2-volume CDC publications, The Public Health Impact of Needle Exchange Programs in the United States and Abroad, and chaired the National Academies of Engineering, Sciences, and Medicine Committee that wrote a framework for educating health professionals to address the social determinants of health. Her work has been funded by the CDC, EPA, HRSA, and Office of Minority Health, as well as the New York State and Foundation grants. Dr. Lane was the founding director of Syracuse Healthy Start, an infant mortality prevention program in Syracuse, New York. Dr. Lane has developed a model that links the community participatory analysis of her policy with pedagogy called CARE, Community Action Research and Education. Her CARE projects include food deserts in Syracuse, leading poisoning in rental property, health of the uninsured, and her current project on neighborhood trauma and gun violence. She is a founding member of the Route 90 Collaborative, a network of colleges and universities implementing innovative education for healthcare students, integrating interprofessional education, engaged learning, university and community partnerships, and the social determinants of health. Now I will turn it over to Dr. Lane for her presentation.
Thank you very much. Can everybody hear me? I guess so. Okay, so first is a plug for our publication, and this was published by the National Academies of Sciences, Engineering, and Medicine in 2016, a framework for educating health professionals to address the social determinants of health. By health professionals, we mean people who help with health very broadly, including clinicians such as physicians, nurses, dentists, pharmacists, and people who work on a population level of health, for example, public health people who work in a more therapeutic or social aspect of health promotion, such as social workers and community outreach workers and therapists. So we take this very broadly. The framework, which we wrote about and you can read about and download in a PDF that's free, includes innovative and experiential learning, because we felt that students best learn about social determinants of health by ideally getting outside of the educational institutions that they're studying in, and interacting with community members. So one of the key things is reciprocal engagement with community members to focus on their priorities, and also teaching students how to take action. And so for taking action, I want to put another plug out there. Dr. Mona Hanna Atisha, she is the pediatrician from Flint, Michigan, that was responsible with her community colleagues for alerting the world to the Flint water crisis. And I believe she is a preeminent example of a physician, of a health professional who takes action. So once we wrote and published the framework, my colleagues in upstate New York wanted to test it out, because what we wrote in the framework was the best that we could do at that time. I still stand by everything we wrote. I like it, but we wanted to test it out. And so we pulled together a group of people from all upstate communities. Those communities are connected by Route 90, the interstate thruway that connects our cities. And that's the University at Buffalo, which is a SUNY school, Syracuse University, Upstate Medical University, another SUNY school, Lemoyne College, and the Sage Colleges in Albany. We have colleagues from each of those departments and others who have joined us. And here I want to give a shout out to Patricia Cuff, who is the director of the Global Forum of the Institutes of the National Academies, of Engineering Sciences and Medicine, who's joined our collaborative. So what are we doing? We are working together to support each other in trying to integrate into our courses elements of the framework that we all have tried before. This is not anything entirely new to us, but the framework provides for people who are trying to integrate these innovative kinds of education and the social determinants of health into their teaching. And that's including lifelong education, not just the basic education that students have to qualify for their professions, but the lifelong learning that they do to keep active in their professions. So we've shared curriculum, we've shared evaluation materials. We can send you some of this. We are jointly publishing the results. We've published one article so far. Another is under review. We have another in process. And so these efforts have been very interesting for us. Let me tell you about a few of them. First of all, each of us in our own area has expertise that we've developed. For example, Professor Rob Keefe at the University of Buffalo works in perinatal mood disorders. He's in the School of Social Work. And his work focuses to a great extent on families of color living in poverty, living in neighborhoods that are often violent, and the children are exposed to lead poisoning, and the parents have perinatal mood disorders, including postpartum depression. And so he works extensively with community groups in Buffalo who address the needs of families of color with regard to depression and additional kinds of emotional difficulties. In Syracuse, we work very closely with a community group that we've helped to write grants with, and their name is the Street Addiction Institute Incorporated. They work on neighborhood violence and neighborhood trauma that the members of the neighborhoods face due to elevated gun violence. In 2016, for example, the city of Syracuse had the highest rate of gun murders of any city in New York State, and we were close in that year to the level in Chicago. We also have the highest rate of concentrated poverty among people of color in the country. So that's something that we want to make better. It's a really hard issue. We've worked closely with our community colleagues, studying ideas that they had with them collaboratively, publishing with them, and helping them to get their own 501c3 so that they could take the lead in working on issues of violence. Once we wrote the framework and started to test the framework, we asked them to join us. And this is an example of what people in each of our Route 90 collaborative institutions have done. We asked the colleagues from Street Addiction Institute Incorporated to come into the classroom and teach our students. In teaching our students, they were helping to develop the curriculum. Then they helped us to bring the students outside of the classroom into community centers where the students, and in one case it was really remarkable, we've done it 4 years in a row, students from marriage and family therapy and the School of Social Work, who are future therapists, learned from the Mothers Against Gun Violence what it was like to see your child gunned down in the street and what the aftermath of the family was, and helped the students to understand that this is not simply a call for hospice-type care for grief, where a family member might die of lung cancer, for example, and then the family grieves, which is really a tragedy. But this is an ongoing set of tragedies that are unpredictable, and people living in those neighborhoods can't really predict what's going to happen next, and that adds to their trauma. So this ongoing work, collaborating with community members dealing with the violence and future therapists, has helped the therapists, we believe, to better target their professional work. Similarly, an ongoing course developed by Dr. Andrea Shaw and Dr. Talisa Stewart of Upstate Medical University draws on interprofessional education to link students who are medical students, health professional students, anthropology students, public health students, and one exercise science student, all paired together. And each 2 students is linked with a refugee family in the community. In this case, they work very respectfully with the Catholic Charities group that handles the Syracuse area refugee resettlement. And the students do home visits with the refugee families. Having the refugee families work with the students to identify the social determinants of health that the refugee families face, and having the refugees' families tell the students what they need so that the students can take action. Do the students take action in the first semester of this course? No, not many of them do, but they know how to take action. They're learning how to take action. And taking action is always done in collaboration with community groups. A third example of this is the SAGE colleges in Albany, where a whole new doctoral program is based on helping students of various health professional disciplines to understand and take action in the social determinants of health. One last community collaboration that has very much been used by our team of the Route 90 Collaborative to teach their students is the Physician Assistant Program at Lemoyne College. And that program links with a free clinic for the underserved and uninsured for medicine and a clinic for dentistry, run in collaboration with a local cathedral, and that is the Emmaus Clinic. And the Emmaus Clinic has a long history of welcoming students who want to volunteer or use the clinic for their degrees, for their internships, for their practicums, etc. So our students and the faculty at Lemoyne Physician Assistant Program and that clinic have collaborated to bring the lessons of the kinds of health faced by the uninsured into the classroom and bring the students outside of the classroom. Again, in this case, it is also interprofessional because students are working collaboratively with many professionals outside of the discipline that they're studying, and they're linked with fellow students from other disciplines at the same time. So to sum up, I don't want to take too much time. The framework that we've written has great elements. I'm very happy with the elements. That having been said, it might be that certain faculty want to take one or another of the elements of the framework and adapt them in traditional courses. If people are developing courses from the beginning, or like Sage College, developing a whole doctoral program from the beginning, then yes, they might be able to use all of the elements. But don't be put off by the fact that we have recommended all the elements. If you want to use one or another of the elements, members of our Route 90 framework would be happy to talk to you on the phone, send an email, help with ideas about evaluating. And the really important thing is, even though I have to admit this is much more work than traditional teaching, the responses of the students are overwhelmingly positive. The students have stopped faculty members in the the corridor and said this was the best course they ever took in their lives. Community members who were part of this have come back to school and gotten additional credentials. And the community members also overwhelmingly have expressed pleasure that the students are coming to learn from them. So that's it. Thank you.
All right, thank you very much, Dr. Lane. Now we will have Dr. Deborah S. Clements. Dr. Clements is the Nancy and Warren Fury Professor of Community Medicine and Department Chair for Family and Community Medicine at the Northwestern University Feinberg School of Medicine. A nationally recognized educator, Dr. Clements has held multiple leadership positions with leading national organizations for medical education, including the AAFP, ACGME, the AFMRD, and the OPDA. In addition to department chair, Dr. Clements is also the program director for the Northwestern McGaul Family Medicine Residency Program at Lake Forest. Now I'll turn it over to Dr. Clements for her presentation.
Thank you so much. I'm so thrilled to be with you and to follow these three great speakers. So one of the ways that we can address health inequities is through the education of our providers. So I'm delighted to see all the maps that we've used and how things have been depicted so far. I want to express my gratitude to HRSA for giving us the opportunity to conduct our work and to establish a national collaborative for education to address the social determinants of health. So you've already seen this definition. I guess the way we think about social determinants of health is it's the causes behind the causes, or really the root cause of disease. So, for example, if you think about a bucket full of health, and the bucket has a hole in the bottom of it, as healthcare providers, we can mop up the loss and even squeeze some of that back into the bucket, but eventually health is going to be lost. And so until we teach our students and residents both the what and the how, we really fall short of what's possible for the health of our society. Really consistent with the data we've seen earlier, we see what happens in medical education. So we conducted a survey of 132 family medicine and internal medicine residents in our environment. And you can see that while medical schools seem to be doing a pretty good job, 84% of the residents said they did receive some training, their ability to both identify social determinants of health in the practice or even discuss those challenges with their patients are fairly low, 28% and 14% respectively. So we've got a lot of work to do. So we set out to establish both a compendium of curriculum resources and to develop some of our own internal resources. Through the collaborative, we did a comprehensive literature review to really identify what resources had already been published, and as well as some good educational work that's clearly being done around the country but not published, especially in graduate medical education. We also reached out through the networks we have and the organizations in medicine to identify unpublished work that we may want to include in the collaborative. Our goal, ultimately, is to create a community of practice that addresses these knowledge gaps and helps us to make better physicians. So this is an example of what you can see if you visit our website. When users enter, there's a compendium of resources that are available, and we hope through the survey function to be able to expand our resources. Of note, I think, is that the ACGME, which is the Accreditation Council for Graduate Medical Education, requires all programs to have some of their faculty involved in research, and soon will require evidence of education of all residents of all specialties in social determinants of health as a result of their common program requirements. We think this is a perfect opportunity to achieve both the research and meet the requirements for accreditation. Now, I'd like to talk a little bit about a resource that we've investigated and have used to develop some curriculum in a family medicine program. So in our environment, we explored this product, the Churn product, that allows us to create compelling data maps for our residents and engage them in identification of local community resources. And while we've always been able to get this data for quite some time at the zip code level, big data now really permits resource identification at nearly the city block level, which is a vast improvement over the zip code data. For example, when you think about the recommendation that we use to consider lifestyle modification, we give excellent advice, but patients who live in food deserts or with limited access to safe recreational facilities really have substantial difficulty making meaningful change, and they may be really unlikely to share these concerns with their providers, many of whom don't live in these areas and don't have an awareness of what is available. Through GIS resource mapping, we have a tool that we can use in either pre-visit planning or as an after-visit summary to really assist the care team and the patient, often being able to send this kind of information as a takeaway with the patient about resources that are available in their community. So what have we done specifically in our family medicine program, and why is this important there? I want to talk just a little bit about the communities we serve. We embarked on this pilot curriculum program in one of our family medicine programs because of the diversity that exists in the program. Lake County, Illinois is comprised of several richly diverse communities that are located north of Chicago, on beautiful Lake Michigan to the east, and rural small communities to the west. Within a 15-mile radius, our residents and faculty practice in 3 very distinct communities. And while we can represent these differences in a variety of ways, for today's discussion, median income is a good representation of how distinct these are. So we work in 2 clinics, one in Waukegan, Illinois, where the median income is just close to $46,000 a year. Our second clinic is located in Grays Lake, Illinois, again, just a mere 15 or 20 minutes away, where the median income is almost $90,000 a year. And then the hospital in which we practice is located between the two in Lake Forest, Illinois, where the median income is significantly higher, almost 3 times what it is in Waukegan, Illinois. So we know geography matters. You know, as most of us are aware, excellent clinical care includes serious consideration of each patient's life experience and the impact that their psychological state and their social surroundings have on their health. We know from past work, from the research that was quoted earlier, that what makes us sick is only about 30% attributable to our genetics. The rest is primarily tied to lifestyle choices and education, and the cause behind these causes are closely linked to social determinants of health. The learners must be aware of these factors, and they need to access a variety of different data elements across several of the social determinants of health domains to really understand comprehensively what the patient needs. And there's lots of moving parts. So despite the social determinants of health, there's also variability from person to person, and so that variation needs to be appreciated as well. As depicted here, the relationship between social determinant of health indicators is complex, so none of these are considered in isolation. There's lots of mediating and moderating factors related to health status, and none is more important than the other, which really presents quite a challenge at the point of care. You know, one of our residents really stated it pretty eloquently for me. She described it that as when she's in Lake Forest, she said she can provide physical therapy information for patients to share with her personal trainer. When she's in Grays Lake, if she needs to order physical therapy, she writes out a referral, and the patient may have to take time off work. It may be inconvenient, but they typically get it done, and we get a report back. When she's in Waukegan at that clinic, she has to get down on the floor and demonstrate to patients what they can do at home because they're not going to be able to access physical therapy independently. So our ultimate goal is to teach our young physicians to practice this way, regardless of where they ultimately work, to know about the patient outside of the exam room, and to work within communities with the community leaders and legislators to improve health equity, again, outside of the clinic. So how do we really, I'm skipping through these because we are short on time and I want you to be able to ask questions. So we used geospatial coding to give residents an indication of both what resources were available, but also to help them explore what they thought were important about social determinants of health and to assist them with disease management and awareness of resource differences. So the inclusion criteria for our study were adult patients who carried a hypertension diagnosis. Our 7 residents in this practice mapped out 195 patient addresses and looked at what resources were available to those patients based on their street address. At the end of the work, they also completed an evaluation survey about their thoughts about social determinants of health and how they felt that might impact care. These data really remarkably parallel the data we saw earlier about practicing physicians. And so in terms of mental health assistance, our residents thought they wished they could write a prescription for mental health assistance. 69% did so, and 62% wished that it was paid for by our healthcare system. And so we looked at how responsible they felt and how accountable they felt the healthcare system should be. In terms of housing, nearly half of them thought they should write a prescription. 23% believed it was not the responsibility of the healthcare system to assist with housing. And so here we see that residents realize that housing is a critical component but not necessarily of healthcare. This told us they don't yet have an understanding of the stress that housing insecurity can cause and the impact of that on a disease state, in this example, hypertension. The other surprising result we received was adult education. Very few of the residents thought that they should write a prescription if they were able for adult education assistance, and very, very few wished it was paid for by the healthcare system. We found this a little bit surprising because, again, in Shorter Lives, Poorer Health, the IOM report, we know that this factor may be the single greatest impact on health of both individuals and families. And not surprisingly, I think it's very important that it's easily recognized that food insecurity is most proximate to the hypertension diagnosis we used in this study. So overall, we identified that the tool was valuable to residents at the point of care to really think about what resources they could provide to patients. So what were the downsides? The downsides were there were too many clicks. Embedding and geocoding systems into the electronic health record really seems to be the answer. Now, I just heard that some of the major systems are moving in this direction. This is really going to help advance our efforts to create a more national plug-and-play curriculum that is used with far more ease at the level of the resident. We also need to think about creating a more iterative model that validates the resources available, but also provides a feedback loop regarding whether or not patients actually use the resource and how do we improve communication between community agencies and the medical home. And I'm aware that there's a tool coming out called Aunt Bertha that creates this kind of model. But overall, I think the horizon is very promising in medical education. And again, our goal is to help residents understand as they become physicians, they need to think about the patient in the context of their family and their community. And health is created there and not at what we can do at the point of care. So thank you very much. I look forward to hearing your questions.
All right. Well, thank you, Dr. Clements, for that wonderful presentation. Now you'll see on your screen a short poll regarding our presentations today, so please take 1 or 2 minutes to complete that. While that's being done, I would like to offer a big thank you to all of our presenters. These are wonderful presentations and very informative. We do have a few questions that came in the chat pod that we'll try to address, but we are limited on time, so we have about 5 minutes. So I will address some of the questions that I have seen typed in the chat pod already. So one was for Dr. Eichen. How significant are suicide and the opioid crisis in driving life expectancy difference by zip code and county?
I'll just answer that now. We commissioned a study of all California counties looking at white mortality rates, and we found that 28 counties in California are showing increased white mortality rate, and the primary causes of death were drug overdose, which we ascribe a lot of that to opiates, suicide, and then the third cause was alcohol-related organ disease, so liver disease and organ failure from alcohol abuse. And when we looked at the numbers, it looked like opiates were about a third, suicide was about 25%, and alcohol-related disease was another 25%. So, and then there were other causes. So, I wrote an op-ed basically saying that, it's not really an opiate epidemic. It really is something much more fundamental. Suicide and alcohol-related disease are almost as significant, at least in California. So suicide is a big piece of this as well.
All right, thank you, Dr. Eichen. So this is for all presenters. So the question would be, the question is, what are the next logical steps that we should take for the community in continuing this work?
I can speak from an educational perspective. The next logical step for us is refining these curricular concepts and making sure that they're available to all of medicine, so that we can raise our new physicians, our young physicians, to really believe in these concepts and understand that health goes way beyond just the clinic or the hospital.
I'd like to say something. Can you hear me?
Yes, ma'am.
Yes, we can.
Okay, so I think one of the next logical steps, based on what the previous speaker just said, is yes, we need to work on the curricular materials, but we need to have an acknowledgement from the accrediting bodies and from the administrations of the universities and colleges where healthcare professionals are trained, that this is important, because right now there are individuals giving lip service to social determinants of health, but it's really the largely overworked faculty who are committed to this kind of thing, who are doing it a lot of times on their own and without a great deal of support.
Yeah, and I would just add that, you know, I think it's hard to come up with one thing. I always find it difficult to think about this in terms of silver bullets. I think that, you know, changing the curriculum for both nursing education, medical education, and other forms of health education is critical. And so I really do salute the efforts that have been made in that space. But fundamentally, these folks have to come out and be able to find jobs that allow them to exercise this newfound understanding. And the only way that this changes is by changing the incentives within the healthcare delivery system, and primarily the finances, financing incentives. So healthcare delivery entities have to be incentivized to move upstream. They have to, their reimbursement has to be conditioned on their ability to reduce things like obesity, increase high school graduation rates, facilitate things at the community level that we know correlate well with better population health outcomes. So until those incentives are restructured, and I think HRSA can have a say in that, these newly trained health practitioners won't have meaningful opportunities to practice the newfound skills that they acquire.
This is Jan, and I'm not, except in the context of educating public health students, not directly in the workforce business. I do sit on a graduate medical education committee, and I understand CLEAR and all those other problems. But one of the things I think we also need to be teaching our physicians, our pharmacists, our nurses, our social workers, is the need to look outside the healthcare system and not say, well, the healthcare system has to change to do it all, but to recognize that we can pair with others. Here in South Carolina, we did a year-long Rural Health Action Plan planning process where we brought together, like the heads of the State Department of Education, people who in the state who are worried about employment, people in the state who are active in the housing industry. I think what we need to teach young practitioners, if you will, is that it's okay for them to allocate some of what little personal time they may have or choose to have to working with people who can obtain the goals that they want within the relevant spectrum. Like, reach out to whoever is in charge of your housing administration and see what they can do rather than trying to do it all internally. If, you know, I'm a great believer that I can't do anything, but I have a Rolodex and I have friends, and my friends are in many places, and I think that's the sort of perspective we need.
All right, well, thank you to all the presenters for addressing these questions, and thank you again for these wonderful presentations. At this time, we will go ahead and end our presentation for today. For further information regarding HRSA programs, please check out our website at hrsa.gov, and the recording and slides from today's presentation will be posted to our Grand Rounds webinar site